So thank you very much. It's truly an honor to be back here. I was last here the month that COVID came upon us. It seems such a long time ago, and just a privilege to be invited back again. I really want to thank and congratulate Dr. Patel on a fabulous meeting, and also to thank you all for being here. And I know that many of you have traveled long distances to be here, so we very much appreciate that. So I'm going to move from the technical aspects of PCI to our medical management of these patients. I have nothing to disclose, and what I'm going to talk about in this short period of time is just a quick recap on what short DAPT is, talk about the bleeding and the high-risk bleed patients, what is antiplatelet monotherapy, and what's holding us back? Why are we not doing this routinely? And then a moment just to draw your attention to de-escalation strategies. Now, short DAPT, again sort of defined as short DAPT followed by P2Y12 inhibitor monotherapy. There have been a number of trials. These are just 4 of the trials here. And this has become an increasingly popular strategy to decrease bleeding with DAPT after course of treatment. And I'm just going to illustrate this, where this may play a role with a couple of patients here. So these are real patients. This is an 85-year-old patient with a non-STEMI. And you can see his medical history there, CVA, has diabetes. But importantly, he has a history of renal stones, and he has frequent hematuria and recurrent anemia. So with this non-STEMI, he was loaded with aspirin and clopidogrel. He has critical LAD, diagonal bifurcation disease. He has 2 drug-eluting stents placed. There are no complications, and DAPT was continued in the hospital. So the question then is this a patient, because of his history of bleeding, is this a patient that we should be considering shortening his DAPT course and then switching to a P2Y12 inhibitor? And if so, which one would we use and for how long? Here's another case though, and this is very different. This is an 87-year-old man. He had GI bleeding. He had severe angina with this, and he had a recent diagnosis of colon cancer, which was the cause of his GI bleeding. He has diabetes. He had very severe peripheral arterial disease. You can see he had various femoral vascular procedures, and he's also got a carotid artery stenosis. Now, in the workup for his colon surgery, he was seen by a colleague of mine as well as an anesthesiologist, and he had a stress test. Now, you could argue whether or not a stress test is necessary in this case, but that's another discussion. It was a very high-risk positive stress test. As I said, hemicolectomy had been planned, but he continues with severe angina. And so my colleagues strongly recommended that he needed to have an angiogram before he had his colon surgery. And this is when I first met the patient. And so then the question, of course, is, well, what are we going to do? Well, if we find something on an angiogram, we're going to have to give this patient DAPT. He's already bleeding. He needs colon surgery. We need to treat this tumor. So PCI, we did the angiogram, and of course we found the worst possible thing. This is why he had such a positive stress test. He's got critical distal left main. This is Medina 111. And so what are you going to recommend now for this patient? Are you going to revascularize? You're going to ignore this? You're going to send him for surgery? He had no intention of having bypass surgery at 87. So this is not so easy. And I can tell you, though, that we stopped, came up with a plan. We did transradial, no circulatory support. You can see there we did PCI. We also used IVL, mini crush, same-day dismissal from as an outpatient. And here's what we had done. We gave him aspirin and clopidogrel for 30 days. He actually had another bleed on DAPT, had a transfusion. And then we discontinued the aspirin and convinced the surgeon to do the hemicolectomy on clopidogrel alone. Totally successful, no bleeding, no complications, and the patient was left on clopidogrel. So this has really worked its way into both the European and the American guidelines here. And we know that at least the guidelines haven't changed in view of the fact that, so this is our highest risk patients, the ones who have ACS, that you're going to continue DAPT for 12 months. And the guideline was always, if you are not at high risk of bleeding. That's always been in the guidelines, or for as long as I can remember. But now at 1 and 3 months, and this is really where the DAPT was abbreviated. These are the time intervals in the trials, the randomized trials. And it's now a 2A recommendation. You can go to PTY12 inhibitor monotherapy. After 6 months, you could potentially choose aspirin as monotherapy, but not a lot of data to really guide us there. But obviously that's what is often done when we have a patient who has bleeding. But here are some caveats on these short DAPT trials. These were all open label, so there's always potential bias there. But the Twilight study, which is one of the largest ones, which was stopping ticagrelor after stopping aspirin after 3 months and continuing ticagrelor alone, that was blinded. These were non-inferiority designs. And again, that potentially is a weakness if you're looking particularly for ischemic events, but there was no signal of harm for ischemic events. It was underpowered for stent thrombosis, but I think that's something that we can just about dismiss. You know, this rate of stent thrombosis now is probably no more than 0.5%, and you're going to need tens of thousands of patients to prove that there's going to be any risk of harm with stent thrombosis caused by de-escalating your therapy. There's been no trials. All these were two-arm trials. It was DAPT versus monotherapy with a P2Y12 inhibitor. There were no trials that then put a third arm, which was aspirin alone. So we don't know whether aspirin is going to be effective and safe within the first few months as monotherapy in our patients. Now, many of these trials included many patients with non-STEMI and STEMI. But still, if we look at the whole, this collective number of patients, there's still probably not enough STEMI patients to really guide us on this. And I think we really need to probably have a dedicated STEMI or acute myocardial infarction trial. The other thing I would point out is that these abbreviated DAPT trials were predominantly done with the use of clopidogrel in East Asians, and where they have a very high prevalence of CYP2C19 polymorphisms, up to probably 40–50% of these patients. Those trials were done without any genotyping or guidance in terms of whether or not they were going to be a responder, whether they're an intermediate responder or a non-responder to clopidogrel. And as I said, predominantly in East Asians, apart from the Twilight study and the Master DAPT trial. And we heard this morning, I think Dr. Patel, you raised some concern about what role this may play in the South Asian population. So then we really at this crossroad here of this uncertainty. So what we're trying to do here is we're trying to balance that bleeding risk and reducing that and making sure we don't increase the ischemic risk. Are there risk scores that we could use? And I'll point out that the only risk score that's been validated in the DAPT population is the precise DAPT score. This is easily done, as you know. It's just a risk calculator out there on the web. It has all the information you need. But as clinicians, like the cases I just showed you, it's pretty obvious. I don't need a risk score to say that this person is going to have bleeding because he's already having bleeding. So that may be very obvious. And there are other factors that are often not taken into account. Older, frail patients, and particularly those who have advanced CKD, these are high-risk bleeding patients. On the other hand, it's not so easy to define what is high-risk ischemia. I mean, so we're talking about the complexity of PCI. And as we've seen the last 2 days, there wasn't a simple non-complex PCI here. And in our practice, we're doing complex PCI every day, long stents, bifurcation, left main, unprotected left main, etc., etc. The highest risk is in our ACS patients, those with a non-STEMI or STEMI within the first 30 days. Then the risk starts to diminish. The risk of bleeding, though, stays about the same, but most of the bleeding still occurs within the first 30 days or so. And so I would just challenge us to think about what do we define as complex PCI, because if you do not want to use DAPT because you say it was complex PCI, then you're never going to be thinking about using DAPT because you say my patient was too complicated. And again, clinical features, probably one of the most important, often overlooked in terms of risk of an ischemic event, is in our CKD patients. So what are the practical aspects? And that's really what we're here to talk about today. Which agent should we use? Well, we have clopidogrel, and that's where most of the data come from. It clearly decreases bleeding with no ischemic penalty, as I said. Ticagrelor, but for the twilight, sorry, I'm jumping ahead here. The no ischemic penalty. So ticagrelor seems to be a reasonable drug to use here. Clopidogrel, the same benefits, but with caution in our ACS patients. So in the DAPT-2 acute coronary syndrome trial, there was a signal that there was a slightly increased risk of myocardial infarction. So it did not meet the non-inferiority criterion, but that difference actually was, in absolute terms, was less than 1%. So, but a word of caution in those patients. Prasugrel, we just don't have enough data. And aspirin, as I pointed out earlier, in the first 6 months, we do not have any good data in terms of abbreviating DAPT and then leaving them on aspirin and stopping the P2Y12 inhibitor. And as I've also pointed out, there's been no head-to-head comparisons with any of these agents with aspirin or against each other. And so when should we think about switching to monotherapy in the ideal patient? Well, again, the trials, it's like 1 month or 3 months. In the DAPT-2 ACS trial, which I mentioned a moment ago, that was at 2 months. And that's when they went to clopidogrel as monotherapy. What about less than 30 days? We have patients that we're going to be nervous about bleeding for the next week or 14 days or so. We just don't have enough data. There are a number of trials that are starting to look at that. We're actually doing one ourselves, at least a proof of concept and safety standpoint. But at the moment, I just would have to caution you that we don't have enough data. And what about getting back to this high complexity of the PCI procedure? So this has been looked at in a number of these trials, particularly in the Twilight study, and looking at patients who had complex PCI as however they wanted to define, and it's usually the ones that I was talking about before, bifurcation, long lesions, multiple stents. They seem to derive the same benefit and decrease in bleeding with no ischemic penalty to pay. But again, just a caution, in those trials, the selected patients, only about 20% of these patients appeared to have complex PCI as however they define them. The majority of these patients in these studies had stable coronary artery disease. And so if there's a population that we should be thinking about, it's that stable coronary artery disease population. If you want to get used to doing this and get comfortable with it, that's the group of patients that you should focus on. As I said, how do you define complex PCI? I already pointed out that STEMI patients are underrepresented, and so maybe if we put those two things together, maybe the ones we have to be a little careful are the ones who present with an acute MI, particularly STEMI, and have had complex PCI, and we see many of those. Maybe those are the ones that we should just have a really good reason to abbreviate their DAPT. Genotyping, I've mentioned already. There hasn't been any trial that's looked at the questions of genotyping versus no genotyping in this population asking this question about shortened DAPT. And it wasn't routine in the East Asian population, and they didn't seem to see any harm. I think the only ones we have to be careful about are the poor metabolizers. This is about 2% of patients who have these polymorphisms. But nevertheless, even though we don't routinely do genotyping, I personally have found myself doing it a little bit more frequently now because I don't want to miss these patients. The intermediate metabolizers are probably okay. And as I said, the duration of therapy here remains uncertain. Do we stop it at 1 month? Do we stop it at 3 months? And then when we go to monotherapy, how long do we continue that for? And what if the patient needs a surgical procedure in a year's time? Can we do that on clopidogrel? Remember, No one wants to operate on clopidogrel and aspirin, but you have to remind people, but they're not taking the aspirin. And maybe all the aspirin is doing is increasing the risk of bleeding. And then in terms of long-term use of these agents, this is probably the best data that we have. And this is now thinking about, so what is the monotherapy you should use? Should it be aspirin, as we often use now, or a P2Y12 inhibitor? And this is probably the largest and most comprehensive analysis of this. This is patient-level data from 7 randomized trials. These are patients with established coronary artery disease, and 2 of them were focused on PCI patients. And you can see that in patients who were randomized to P2Y12 inhibitor, and most of these were clopidogrel, versus aspirin, you can see that the event rate was significantly lower, and it was mainly by decreasing MI. So I'll repeat that. Decreasing MI with an agent such as clopidogrel or ticagrelor did better than with aspirin. Bleeding was the same, and it certainly wasn't more. So I think that's something we really need to understand, that the risk of bleeding on aspirin is not less than the bleeding if you're on clopidogrel or ticagrelor alone. They're the same, and it could even be lower with a P2Y12 inhibitor, particularly for GI bleeding. And the net adverse clinical events were lower. And you can see here in that analysis, this Panther group, you can see all of the event rates there all favored a P2Y12 inhibitor as monotherapy. And the final thing I would just say, just in the last minute here, is as we think about the choice of antiplatelet therapy, ticagrelor and clopidogrel and prasugrel come from the Triton and the Plato trials, but these are 20 years old. The landscape has changed, and I've got a list of things there, but I think it's related predominantly to better medical therapy, particularly with wider spread use of high potency, high dose statins, and the stents just got so much better. So today, if we did Plato and Triton all over again, would you replicate the results? Well, I'll let you ask yourself that question. I suspect not. And that just brings me to the last of the data slides here. And I've been talking about short DAPT, abbreviated DAPT. This is a different strategy. This is de-escalating from ticagrelor or prasugrel to then clopidogrel along with aspirin. And this is the Taylor-MI trial. This is, again, a South Korean study. And de-escalating after 30 days from ticagrelor to clopidogrel. And you can see there that after 30 days, the patients who were then randomized to receive clopidogrel rather than ticagrelor did better. Less ischemic events and certainly less bleeding, and you can see the number needed to treat to obtain those benefits. I know I've just gone maybe a minute or so over here. There are going to be many things that you will see. There's now a consensus statement, and they're a little complicated, but I think you should think about this in simple terms. Assess your bleeding risk after PCI of your patient. And if there's no increased risk of bleeding, and there is no increase in ischemic risk, then why subject them to DAPT for a long time? They're low risk for bleeding, low risk for ischemia. Let's just go to a P2Y12 inhibitor. If they're at high ischemic risk, however you want to define that, then okay, then standard DAPT, because they're not at high risk of bleeding. But what if they're at high risk of bleeding? If they're not at high ischemic risk, and again, think about your stable angina patients, then short DAPT. This is where I would separate, where I would steer away from, choosing the wrong word, where I might not totally agree with what some of the statements that come out, because I think they're unnecessarily complicated. The high ischemic risk, high bleeding risk, maybe prolonged DAPT, it's not worth the risk for bleeding. But some of the guidelines and consensus statements say that you should continue ticagrelor and prasugrel, and I think that remains to be seen. That's an open question. So in summary, I think that we now have a promise of simplifying antiplatelet therapy. And I think if you have a patient who has actionable bleeding, is clearly at high risk of bleeding, or needs urgent surgery that cannot be deferred, you should be confident you can de-escalate your antiplatelet therapy and move to a P2Y12 inhibitor. As I said, be careful about the ACS patients, have faith in the stent, and all these patients that you've all been seeing treated for the last couple of days, they're going to do great from an ischemic standpoint. What's their biggest risk now is bleeding. Once you come out of the cath lab, your ischemic risk with a successful result is pretty low, but your bleeding risk doesn't diminish. It actually begins then. And so the take-home message here, use less aspirin. Thank you so much for your attention.
Malcolm, I have a question. Is the practice homogeneous amongst the interventionalists at Mayo Clinic? About this. So most of you use short-term DAPT or?
Yeah, the simple answer is no. Because it's all relatively new and everyone has a different definition of their patient who's high risk. So I think eventually it'll be harmonized, and I think we'll have a more consistent approach. But some of us are more comfortable doing this than others, but it's an increasing number of patients who are being switched to monotherapy after 30 days or 3 months, particularly in the patients with high risk of bleeding. So we are doing it increasingly more, but I think we're in a sort of an initial phase of change.
Because in India, because of this very spicy food, there is always some erosion and bleeding and a sudden drop in the hemoglobin. And all our gastroenterology colleagues, they are telling us that the evidence is against aspirin. If you want to continue one, then no aspirin. You may continue with maybe clopidogrel or Brilinta. Is this the same at Mayo Clinic?
It depends who you're speaking with. I think part of it is being maybe agnostic of what the literature is, but I think for years we've known that aspirin causes more gastric and duodenal erosions and more GI bleeding, and I think it's been known for some time that you actually have probably less bleeding with clopidogrel than with aspirin. And in that Panther collaboration, I mean, that included the studies such as the Capri trial, and that was 20-odd thousand patients randomized, double-blinded to clopidogrel versus aspirin, and there was less bleeding, certainly no more bleeding with clopidogrel than there was with aspirin. But it's the GI bleeding is going to be more with aspirin.
The last question, our surgeons, even, non-cardiac, some gastrosurgeon or orthopedic, they are very comfortable, operating with aspirin. But if there is clopidogrel, they will ask us, stop it. And now you talk, in your talk, I could make out that clopidogrel is more friendly as far as this problem is concerned.
Well, I mean, I'm not going to disagree with that, but it's going to be difficult to convince us. So the example I gave you of the 87-year-old man, I sat there and spoke with the surgeon and explained that we're not talking about dual antiplatelet therapy because they're afraid of Plavix. We're taking away the aspirin, and I've had 3 cases like this now, and they did just fine with P2Y12 inhibitor. But it's going to take a lot of education and a lot of experience.
Thank you.
Okay.